Good night, everyone. My name is Dominic Monix, and I will be presenting on the management of pituitary tumors. Okay. So this is just a brief agenda on what we will be discussing tonight. So some key concepts to remember about pituitary tumors are that most tumors are benign adenomas arising from the anterior pituitary. They typically present with symptoms secondary to excess hormonal secretion or mass effect, and workup for a newly diagnosed intracellular lesion involves hormone evaluation and imaging. Finally, prolactinoma is the only type for which medical therapy may be the primary treatment in certain cases. So a brief overview of the gland's anatomy and embryology. The pituitary gland lies in its fossa, the sella turcica, with the diaphragma sellae above it. It consists of an anterior and a posterior lobe, and the majority of pituitary tumors arise from the anterior pituitary gland. So the pituitary gland is developed from the anterior pituitary gland, the adenohypophysis, is developed from an ectodermal saccule known as Rathke's pouch, and it consists of the pars anterior, also known as distalis, pars tuberalis, and a rudimentary pars intermedia. The neurohypophysis developed as an neuroectodermal downgrowth from the floor of the third ventricle and consists of the pars posterior, the infundibular stalk, and the median eminence. Of note, the anterior pituitary secretes growth hormone, prolactin, FSH, LH, TSH, and ACTH, which would be significant when we speak about neoplasms arising from this gland. And the posterior pituitary secretes oxytocin and vasopressin. So according to the WHO classification, 5th edition, tumors of the cellular, there are 5 distinct tumors of the cellular region. The first and most common one that we will talk about is pituitary adenoma, also known as pituitary neuroendocrine tumors. There are also the craniopharyngiomas. Previously, these were the adamantinomatous and papillary craniopharyngiomas were considered to be to be subsets of the same type of tumor. However, with the latest classification, they are now seen as 2 distinct diseases. There's also pituitary, which arises out of the posterior pituitary gland, sorry about that. And then there's the pituitary blastoma, which is a pediatric condition. So the bulk of my presentation will be on pituitary adenomas, as they are the most common. They can be classified as microadenomas, which are less than or equal to 1 centimeter in diameter, macroadenomas, which are more than 1 centimeter in diameter, and giant pituitary adenomas, which are more than 4 centimeters. The management can be broken down into surgical, non-surgical, and surveillance, right? Traditionally, we would have classified these as adenomas, but now we call them pituitary neuroendocrine tumors. It's acceptable to still say pituitary adenoma, though. Okay, so the diagnostic criteria for pituitary neuroendocrine tumor, essentially, we need it to be in a cellular or supracellular location. If it's in the brain parenchyma, for example, then obviously that wouldn't be a pituitary tumor. There also need to be histological features of a low-grade neuroendocrine tumor that displays destruction of the normal anterior gland acinar structure. And subclassification is based on immunoreactivity for pituitary hormones and or lineage-specific transcription factors. So this is something that you would get from pathology. Also, you can find reticulin fiber disruption, low molecular weight cytokeratins, and tumor proliferation as indicated by either the mitotic count or the Ki-67 expression. Okay. Pituitary tumors represent approximately 10% of intracranial tumors, and pituitary adenomas account for approximately 15% of primary intracranial tumors. The peak incidence is at 35 to 60 years old, and they are most common in the third and fourth decades of life. They also affect both sexes equally. But of note, Cushing's disease and prolactinomas are more common in female, while non-functioning tumors tend to be more common in males. The incidence of pituitary tumors is also increased in certain syndromes, most commonly multiple endocrine adenomatosis or neoplasia, also known as MEO-MN, especially type 1, which is an autosomal dominant um, congenital syndrome. Okay? So most cases of pituitary adenomas occur sporadically. Some, which is approximately 5%, have a genetic or familial association. Like I mentioned before, MEN type 1 is a common example of a genetic condition that's associated with pituitary adenomas. There's also Carney complex, which is caused by a loss of function mutation that results in an increase in CAMP activity. These patients present with cardiac myxoma, spotty skin pigmentation, and adrenal gland, testicular, and pituitary adenomas. Okay. There's also familial isolated pituitary adenoma syndrome. So in patients who don't have MEN or Carney and they just have pituitary adenomas presenting in families, then they would be diagnosed with FIPA, familial isolated pituitary adenoma syndrome. And it's the most common familial cause of acromegaly and giantism. Okay. Also, FIPA, if two or more family members have the same type of pituitary adenoma, then it will be considered homozygous, while if they have different types, then it's considered heterogeneous FIPA. Right. So secretory pituitary adenomas, by definition, are tumors that secrete hormones. The most common type are the prolactinoma, which accounts for 40%. And the most common presentation for prolactinoma would actually be infertility. So in women, they may have trouble conceiving and present to their obstetrician for help, and they would incidentally find that they have prolactinoma. Women can also present with galactorrhea, amenorrhea, reduced bone density due to suppression of estrogen. And men have noted reduced libido as well as infertility. Okay. There's also somatotroph adenoma, which secretes growth hormone, resulting in acromegaly or giantism. Acromegaly and giantism are both caused by increased growth hormone. However, the clinical features is different depending on the the state of the patient in regards to puberty. So if the end plates are not fused, as in children, then they would continue growing. The distribution would be even and they would have giantism, while acromegaly is in adults who have fused growth plates, and it results in a coarsening of their features. 5% of secretory pituitary adenomas are corticotrope adenomas, which is Cushing's disease, where you have increased secretion of ACTH, resulting in secondary hypercortisolism. 1% of pituitary adenomas have hypersecretion of TSH, and rarely you can have gonadotrope adenoma, where you have elevated LH and FSH. Only 10 to 20% are actually functioning, while the vast majority are non-functioning. And by that, I mean that they are secreting hormones, but they're not clinically significant. So non-functioning tumors account for 15 to 45% of all pituitary adenomas. And some of the most common types would be, like I mentioned before, well, it's actually rare, but among non-functioning tumors, what comes to mind would be gonadotroph adenomas, null cell adenomas, plurihormonal adenomas, and silent somatotroph and corticotroph adenomas. Okay, so null cell adenomas are defined as pituitary tumors that lack evidence of a specific differentiation, cell type differentiation. So in histology, they wouldn't be able to classify it in any way, and it would not secrete hormones, while plurihormonal secrete more than one type of hormone, most commonly growth hormone and prolactin. Okay? Plurihormonal adenomas um, are known to be specifically aggressive, right? Okay. So the most common presentations are due to endocrine syndromes, whether that be over secretion or underproduction. It can also be due to mass effect. Patients may present incidentally. They may have had a imaging done for some other reason, and they found a tumor on brain scan. And finally, they can present with pituitary apoplexy. So apoplexy is hemorrhaging into a tumor, and that results in features of raised intracranial pressure. Right. So now we're getting into evaluation of pituitary tumors. We always want to start with a history and exam in any disease. And when we're taking our history before we examine, you want to look for signs of endocrine hyperfunction. So look for features of hypothyroidism, um, as well as prolactinemia. You also want to ask about possible endocrine deficits. So hypothyroidism can present in patients as well with pituitary adenomas. We can also assess them for visual field deficits, asking about vision changes. And on examination, we can do a confrontational visual field test, which is just a simple test where we sit face to face and ask the patient to follow your finger. So just look straight ahead and follow your finger in each pattern, and that can assess the peripheral vision. And then finally, we can assess for deficits of cranial nerves within the cavernosinus. Okay. So when we are trying to diagnose a pituitary tumor or investigate a pituitary tumor, we have certain imaging that we like to do. So you want to use imaging to confirm the presence of a pituitary adenoma. You can also do hormone assays to determine whether it's a secretory or non-secretory tumor, as well as whether there are any hormonal deficiencies. And then finally, you want to do formal visual field testing as well. Mhm. Okay. So initially, when we have a patient that we're working up for pituitary tumor, you want to assess their hormone status. All patients, you assess their pituitary axis. You're going to check their cortisol level, their thyroid function tests, prolactin levels, gonadotrophs, insulin-like growth factor 1, and fasting blood glucose. And these could narrow down our differentials for the possible hormones that are being secreted by the pituitary adenoma. Can also do a formal visual field test and any radiographic studies as well. Okay. So Visual field testing, the two most common ones that you can do are Goldman perimetry, which is a manual test where you have a tangent screen. So it's just a screen in front of the patient, and you use a small red stimulus to to check the peripheral vision to see if the patient is seeing. And there's automated perimetry as well, which is actually the gold standard. These both require good patient cooperation. Okay. Also, what's useful about formal visual field testing is that you can have um, an objective evidence the patient's vision before and after surgery, and just over time in general to see improvement or deterioration of their vision. Okay. So when we are assessing the prolactin levels after doing a hormone assay, we need to know what is normal. What's a normal prolactin level? So in a non-pregnant premenopausal female, the normal prolactin goes up to 30, while postmenopausal female patients, it can go up to 20. In pregnancy, prolactin can be elevated upwards to 400, which is significant. And so that's why when we are evaluating a patient's prolactin level, we need to assess them as like assess the patient. Don't just look at the prolactin level, look at who we have in front of us. Moderate elevation is considered 25 to 150, and over 150 is significant elevation. So in this regard, we need to start we need to consider stalk effect and hook effect. So stalk effect is a phenomenon that occurs when there is compression to the pituitary stalk, and prolactin, being a hormone that is under inhibitory regulation, is negatively affected by this. So when you have compression of the pituitary stalk, it reduces the inhibition of pituitary hormone production, resulting in an increase in prolactin. So when you have moderate elevation of prolactin, there's a chance that it may not be a prolactinoma causing the prolactinemia. As a rule of thumb, the percentage chance of prolactin being due to a prolactinoma is half of the prolactin level. So, for example, if we were to take 150, if a patient has a prolactin level of 150, half of that is 75. So that means that there's a 75% chance that the elevated prolactin levels is due to a prolactinoma. On the flip side, that means that there's a 25% chance that is due to something else. Another example, if you have a prolactin level of 200, half of that is 100. So that means that if you have a prolactin level of 200, you have a 100% chance, if you use the rule of thumb, that this is due to a prolactinoma. So that's why it's so significant. That's why it's considered significant to have a prolactin level of more than 150 if we were to consider the rule of thumb. Right? The other effect that I wanted to talk about is the hook effect. And this is due to having excess prolactin levels to the point where the machine in the lab can't read it. So what I mean by that is when you say, for instance, a patient has a prolactin level of 1,000, sometimes the lab will send back a level of 150 because the machine is unable to read it due to the excess amount of hormones in it. And this is not good because we actually need an exact value of the prolactin levels because that can inform management. So to counter the hook effect, we can ask for progressive dilution until the machine can read it and extrapolate what the actual prolactin level is. Okay, all right. So for imaging, the imaging test of choice for pituitary tumors is MRI. So specifically MRI cellular with IV contrast is the gold standard. It's indicated as a first-line diagnostic modality for suspected secretory or non-secretory pituitary adenomas. It can also be used for post-surgical surveillance after resection of a pituitary mass. So on MRI, we would have the characteristic finding of an intracellular mass, and some other things, some other additional findings can be compression of adjacent structures, most commonly or most famously, the optic chiasm. You can also have hemorrhage and necrosis, which is seen in pituitary apoplexy, and you can also identify cavernous sinus invasion on MRI. So this is just an example of what an MRI with contrast would look like for a pituitary adenoma. Okay, so on your left is the coronal cuts, on your right is sagittal. Okay. So some other imaging that can be done in the investigation for pituitary adenomas are CT. It may be appropriate to do a CT. It may be appropriate to do a CT in the place of an MRI when an MRI is contraindicated. So for example, if a patient has a pacemaker and they can't get an MRI, they can use a CT instead. However, in general, the MRI is the gold standard, and you usually will have a CT scan for patients, typically first, because it's so accessible and affordable compared to MRI. It may also be considered for pre-op assessments in the case for transsphenoidal surgery. And if an MRI cannot be done, you can also consider CT angiogram to demonstrate the paracellular carotid and arteries and to rule out any differentials like giant aneurysm. Okay. Angiography can also be done pre-op to localize the carotids because it's important in surgical resection of these tumors, because one of the risk of pituitary adenoma resection is injury to the carotid. And then finally, skull X-ray and fluoroscopy can be used to help define the bony anatomy. CT scan does that just as well, if not better. But intraoperatively, fluoroscopy is used or can be used to help keep the markers of where you are while you're operating. Okay. So this slide is just showing the anatomic classification of invasive pituitary tumors. So I think it would be easier to explain it with a picture. So the Hardy classification uses cellular extension as well as extracellular extension to determine invasiveness. The grades go from 0 to 4 and A to B, respectively. So most severe would be a grade 4, where you have complete spread, diffuse complete cellular destruction across. That's completely invasive for grade 4. And for grade E, so A to E, A is where it abuts the supracellular cistern. B goes beyond extracellular, it goes up to the recess of the third ventricle. Grade C encompasses the whole anterior third ventricle. D invades intracranially, and then E takes over the cavernous sinus. Okay. So NOPS classification specifically is for cavernous sinus invasion, and this criteria has been proposed to determine the degree. So NOPS classification has been proposed to determine the degree of cavernous sinus invasion. And this classification correlates with resectability. There are three important lines when it comes to this classification system. So let me just use my pointer. Okay, right. So there's a medial line, the intercarotid line, which is also known as the median line, and the lateral line. So grade 0 does not cross the medial line. Grade 1 the tumor crosses the medial line. However, it does not cross the intercarotid line. And this would be considered 1.5% invasive. Grade 2 crosses the intercarotid line, but not the lateral line. Grade 3 can be divided into 3A, 3A and 3B. And grade 3 describes tumors that extends lateral to the lateral line, right? So 3A extends superiorly, while 3B extends inferiorly below the ICA. And finally, grade 4 wraps completely around the intracavernous ICA. This is considered 100% invasive, and you would be unable to achieve gross tumor resection, right? Complete tumor resection. Okay, so that was the classification. Now we're getting into the treatment of these tumors. So we can break it down into non-surgical versus surgical, and non-surgical so some non-surgical options would be pharmacological and radiotherapy. We can also observe tumors that may be just incidental, asymptomatic, non-functional. And then there's surgical management, where we have the option to do transsphenoidal resection versus subfrontal approach. And the goal of surgical management is the removal of pituitary tissue. It can be partial or complete. Okay, so just to get into the non-surgical management, first we're going to talk about pharmacological treatment options. Prolactinomas can be managed first line with dopamine agonists. They can cause the adenoma to shrink, and the two most common ones that we use in practice is carbagoline and bromocriptine. And actually, bromocriptine is the one that's used most commonly in our setting. Of note, the other types of secretory pituitary adenomas, first line is surgery. And any pharmacological management is used as an adjunct and very specific after careful individual assessment. All right, so just to get into the details of dopamine agonists, a dopamine agonist is a compound that activates the dopamine D2 receptors. And the most common side effects of dopamine agonists are nausea, headache, fatigue, orthostatic hypotension with dizziness, cold-induced peripheral vasodilation, depression, nightmares, and nasal congestion. So the side effects are wide and varied. Bromocriptine lowers prolactin level to less than 10% of pre-treatment values in most patients. So it actually reduces the tumor size in 6 to 8 weeks in about 75% of patients with macroadenomas, but only as long as therapy is maintained and only for tumors that actually produce prolactin. Just to stress that prolactinomas are the only pituitary adenomas that are treated that can be treated rather primarily with pharmacological therapy. Okay. Carbagoline, important side effect of carbagoline is cardiac vascular disease on top of the others that were mentioned before. And in patients who we would like to start carbogoline, we need to do an echocardiogram prior just to know what their heart valves were like and to know if we even want to start them on carbogoline. Yeah. So surgical management, right? So there are two main surgical approaches to the resection of a pituitary adenoma: transsphenoidal and subfrontal. So the transsphenoidal approach um, can also be done endoscopically or microscopically. You enter the pituitary fossa from below the sphenoidal air sinus. On the left, that picture is an image of an endoscopic resection. On subfrontal, this is where the gland is approached to the anterior cranial fossa by elevating the frontal lobe of the brain. And they both have their risks and benefits. So for the transsphenoidal approach, like I mentioned before, you have microscopic, right? So you have microscopic approach versus endoscopic. The transsphenoidal approach is the best and most typical. The benefits are that it requires no brain retraction and there's no external scar. The risks are uncommon. However, some major risks that we need to keep in mind when consenting patients are carotid artery injury, visual loss, CSF, rhinorrhea, meningitis, and pituitary insufficiency. And it's contraindicated in patients with inappropriate carotid anatomy. Okay. And the subfrontal approach is indicated in patients who cannot get the tumor resected via the transsphenoidal approach, or it can be used as a second stage approach to resection of the tumor after doing a TSR, which is a transsphenoidal resection. It's indicated in patients with suprasellar tumors, patients who have lateral extension into the middle fossa, and anterior extension beneath the frontal lobes. A benefit to the subfrontal approach is that you can actually visualize both of the octave nerves and the carotid arteries. However, it's riskier than TSR because we're actually doing a craniotomy and retracting the brain, right? So you can have various complications from that, right? And finally, just to touch on the other tumors other than pituitary adenoma. So for Cushing's disease, there's a management algorithm where so first, when you start with your imaging and you identify that you do have a pituitary adenoma, if you see a mass in Cushing's disease and the patient has Cushing's disease, then the management would be first line transsphenoidal surgery. And if the MRI does not show a mass, then we can do something called inferior petrosal sinus sampling. This is where you take a blood sample from the inferior petrosal sinus in the skull and determine the level of ACTH. If it's positive, then surgery is indicated. If it's negative, then you can identify a tumor elsewhere in the body with abdominal CT. And finally, if we do surgery and the Cushing's disease is not cured or they're still having Cushing's syndrome despite resection of the tumor, then you can consider re-exploration of the source and offer some other therapies. Okay, and in TSH secreting adenomas, like I mentioned before, the first line for any tumor that's not a prolactinoma is transsphenoidal surgery. And of note for TSH secreting adenomas, these tumors may be fibrous and difficult to remove. So you can offer post-op radiation therapy for patients who have incomplete resection. Okay. And the agents that I mentioned before in the pharmacological slide you can offer medical therapy in patients who would benefit. So in closing, the recurrence incidence of pituitary adenomas after resection is approximately 12%, with most recurring 4 to 8 years post-op. And most tumors demonstrating significant regrowth or symptoms following initial resection, you can offer re-resection. But once the tumor is debulked, consideration should be given to radiation therapy. And if you have recurrence after a second operation, then you can offer surgery again. So, but once there's no recurrence, we do post-surgical surveillance after resection, just to ensure that it doesn't come back and there are no issues. These are my references. Thank you so much for your time.